I'm Dr. James Grew. I'm the Director of Analytics for Healthcare Registries. One of the questions that we receive on a regular basis from providers is how can a payer use clinical outcomes to compare the results of the care one provider delivers compared to the results of other providers? I'm going to show you some analytics from diabetes management that I think answer that question. I'm on the home page of Healthcare Registries, and I'm going to go to the diabetes registry, and I'm going to look at HbA1c change over time. At this first level of analytics, you can see that out of the 3,923 patients in this particular organization, 1,125, the A1C has improved between their previous visit and the most current visit. About 1,500 have stayed stable, and about 1,200 have gotten worse. If I look at the next level of analytics by clicking this plus, I can now see how those break down into different populations. So population management becomes an important way that analytics can be used to improve the outcomes of patients that we're delivering care. This is the first level, so you can see that in this particular office, 227 patients have an A1C between 5.7 and 5.9, 46 between 9.5 and 9.9, 103 between 10 and 10.4. So we can start understanding where these populations fall. If I look at the next level of analytics, I can see that for the patients that in their most current visit have an A1C between 8 and 8.4, this is where they came from the previous visit before that. So you can see that there's 15 patients that improved from 10 to 10.4, and now they're between 8 and 8.4. There's 35 that improved from 9 to 9.4, and they're now 8 to 8.4. So all of these patients in green have actually improved their A1C, therefore reducing their risk of developing retinopathy, as well as all other complications from diabetes. If we look at this group, though, we can see that there's 71 patients that were almost controlled. They were between 7 and 7.4, and now are between 8 and 8.4. We've got 18 patients who were between 6.5 and 6.9, and now are between 8 and 8.4. So this group are patients that have all gotten worse. If I understand this, and I can now start identifying this, you have to understand that this data came from practices that saw that A1C at each of their exams, but it's difficult to put it together to understand how we can actually improve it. By having the data, we can now see that we're going to have a different conversation with these patients that were between 7 and 7.4 this time compared to 8 to 8.4 than we are with the patient that was at 9.5 to 9.9 the last time. That conversation should be completely different based on the principles of healthcare reform, where we engage patients in a way that's unique to that patient. So these patients that have gotten worse, we need to understand why. And that's what I'm going to do as a provider, is I'm going to ask questions to understand why those patients got worse. I also want to know why these patients got better, so I can use that information in helping other patients. So what payers can do is simply watch these trends. If we go back to this first level, what we want to happen is we want more patients to improve and less patients to get worse, and we don't really want them to stay stable, because a lot of these patients we could help reduce that risk. So all a payer has to do is look at the trending in these columns to tell which providers are making an attempt to help the patient or are most effective in helping the patients reduce their risk.